So what you've seen is my research group at the NIH spans the spectrum. It has a basic component and a clinical science component. An introduction to the preclinical aspects, and then you saw an introduction to the clinical aspects. The ultimate goal for everybody in this room is, can we get to a therapy? How can we treat SLOS? As you all know, it's an inborn error of cholesterol synthesis. You have a defect at the 7-dehydrocholesterol reductase that results in decreased cholesterol and increased 7-dehydrocholesterol. That results in a number of problems. Some of the problems are developmental problems or malformations. So they're developmental defects, birth defects. But it is also a biochemical problem in that it's an inborn error of metabolism, and this can result in functional defects. And that is important, I think, when you think about trying to treat Smith-Lemli-Opitz syndrome. Some of the problems, the developmental problems, we're not going to be able to fix. However, if there are functional problems, and I think one of the questions earlier this morning is, what would happen if we treat a child after they're older? Some of the functional problems may be amendable to therapy, and that's what we've been working towards. And this is sort of a statement that has guided my research group, and when I try to justify doing research and developing therapies for SLOS, because many times I get asked, people think of it as a malformation syndrome and say, well, can you do anything for these kids? And I think there is a group we can, and it's really to what extent are the mental and behavioral problems in SLOS due to fixed developmental abnormalities versus functional abnormalities due to the abnormal sterile composition. So malformations versus biochemistry. And this is a slide that I used to illustrate that. And what this is we're looking at the ability of neurons in culture to respond. And here you can see on the left is a normal neuron. And this is a neuron, these are mouse neurons, from a mutant mouse. And those neurons are not working as well. And this is just another way of plotting it. Here's the neurons from the mutant mouse, and this is where they should be. So you can see they're not working as well as the neurons from a mouse who's a carrier, like a parent of a child with SLOS, or a person without the mutation in either of their genes. But when you add cholesterol back, these neurons work just fine. And that argues to me that there may be a functional component that we could maybe make the neurons work better. So the analogy I've used when talking to individuals, if it's a developmental problem, somewhere this is going in and out. If it's a developmental problem, you can think of it like if the nerve is missing, if it never developed, if that nerve cell isn't there, we don't have a way of fixing it. Or if it didn't make the right connections, we don't know how to fix that yet. That's beyond our technology. But if the nerve is there, if it's made the right connections, but those connections just aren't transmitting the signal right. It's like your light switch is a little bit rusty, so the electricity dims it down because the electricity is not getting through. That we can maybe fix, and that's what our goal has been. So what are the therapeutic approaches that you could use? And we've heard about them. You could increase cholesterol. You could decrease the 7-dehydrocholesterol, or you could decrease metabolites, these oxysterols or other metabolites that are formed from the 7-dehydrocholesterol, and they're not normally in our bodies. So these are the approaches that we think about, and I agree. Dr. Steiner mentioned earlier that in his opinion, it's a combination of factors. It's both the decreased cholesterol and increased 7-dehydrocholesterol, and I absolutely agree with that. The different problems we look at, some of them will be due to decreased cholesterol, others will be due to increased 7-dehydrocholesterol or metabolites of it. So The first approach is when SLOS was realized to be a defect of cholesterol synthesis was, well, we know how to give cholesterol. In fact, many of us get too much of it in our diet. So it was dietary cholesterol supplementation was tried. You have to think of the dietary cholesterol supplementation as two parts of the body. Dietary cholesterol will get in our bodies and go to peripheral organs and can have an effect there. But as Dr. Steiner mentioned earlier, dietary cholesterol does not cross the blood-brain barrier. So the dietary cholesterol is not doing anything directly for the brain. And so you have this split of thinking about peripheral body therapy versus central brain therapy. And we obviously want to make the kids with SLOS healthier, so there's an advantage to giving them the cholesterol which their body needs. But our ultimate goal is to try to impact the behavioral and cognitive issues that really impair these kids and limit their quality of life. And for that, we're going to have to think about how to do brain therapy. Cholesterol doesn't cross the blood-brain barrier, but as you heard earlier, there are a lot of anecdotal stories. We give cholesterol, the kids do better. We don't understand what's going on there. It can't be a direct effect. We also have to ask our question, is it real? If you are a scientist, you've got to be pessimistic and say, I need to see data. Because we all want something to work. We're all subject to placebo effects, whether you're a parent, whether you're a physician, anyone. And so to really develop therapies, to ever get them approved, you have to have data that's solid and says, this is a real effect. We're really doing something for these kids. Important because if something is not working as well as you want it to, we need to know that also, so you move on to the next therapy. So there are a lot of anecdotal reports. Elaine Tierney, who is here, looked at a small group of SLOS kids. This was early on, and there was a suggestion that if cholesterol therapy was initiated earlier, there was less of a probability that they would have a diagnosis of autism than if it was initiated later. So intriguing findings of what's going on. How can you test that and see if that's really true? So we set up a study to try to compare behavior on and off cholesterol. Well, how do you do that? We used egg yolk versus an egg substitute that has no cholesterol in it. And it was a short-term study because the anecdotal report said you put these kids on cholesterol and it happens quick. So we only went for 2-week periods. In retrospect, that's probably short, but a lot of parents were very hesitant to take their kids off of cholesterol, period. We only had 10 participants complete the study, so it's very underpowered. What was one of the issues? Everybody thought cholesterol works, therefore why study it? But it's actually important to establish that what we think works is actually working and actually improving our kids. And the outcome measure, no participants discontinued during the placebo phase. So when we took the kids off cholesterol, a lot of parents feared, oh, my child's behavior is going to go, they're going to go crazy. I'm not going to be able to do this. Fact of the matter is, in none of the kids who participated did we have that as a problem. Our outcome measure was a tool called an aberrant behavioral checklist, which is a relatively simple tool that the neurocognitive people use. It was a tool that we could use. It's a report by parents, but it's a tool we could use on a home-based study. Well, here were our results. So when we looked at the total score of this checklist, it was the same whether you were on cholesterol or on placebo. We were having no effect. And on our primary outcome measure, which was the hyperactivity subscale of this checklist, they were actually exactly the same. In statistics, you give a probability that your result is different. And scientists generally say, okay, I want to get a probability value or a p-value of 0.05. It means I have a 5% chance of my result being wrong. Well, the p-value here was 1.0, basically telling you you had a 100% probability that this was just random. They were the same. So the study does have limitations. It's underpowered, needed a larger study. It's short term. The study needs to be longer. So if we really want to know that if dietary cholesterol impacts behavioral and cognitive aspects, we need larger study, we need longer study, and they need to be controlled. There's no controlled, as Dr. Steiner said earlier, there's no controlled studies showing a benefit of dietary cholesterol supplementation on either behavioral or learning. With that said, all of us, I think, do put kids on cholesterol or suggest cholesterol supplementation. But in general, it's not to impact behavioral learning. It's to try to keep the kids healthier. Okay? So the other study that we've done is a study of Simvastatin, or an HMG-CoA reductase inhibitor that got referred to this morning. Now, the initial rationale was to decrease 7-dehydrocholesterol levels, thinking that those may be toxic. And 7-dehydro, here's cholesterol down here. 7-dehydrocholesterol is just above cholesterol in this long biosynthetic pathway. HMG-CoA reductase inhibitors act high up in the pathway. And they're commonly used in individuals who have hypercholesterolemia to lower blood cholesterol levels. So we had done work in the mouse model, I'm not going to show here, that if you give an HMG-CoA reductase inhibitor, Simvastatin, a side effect of that drug is your body says, well, you blocked up here, I'm going to be smarter than you are, and I'm going to turn on this whole pathway. I'm going to make more of these enzymes that make cholesterol. It also increases the amount of 7-dehydrocholesterol reductase enzyme. So a way to think about this is if you have 10% of the 7-dehydrocholesterol reductase activity that you need, and you have Smith-Lemli-Opitz because of that, if you make more of that enzyme, even though it doesn't, twice as much, even though it's not working how it should, you now, instead of having 10%, you have 20% activity. And that was the idea behind this, that we were turning on the gene, and even though we didn't fix the enzyme, it still works. It just doesn't work well enough. But we got more of the enzyme. Still doesn't work well enough, but there's more of it, so the overall effect is better. So this study, had 22 patients enter the trial. 18 participants completed the study. It was a crossover design. So individuals were on either placebo or Simvastatin for 12 months, took a break for 2 months, and then if you were on placebo the first 12 months, you went to Simvastatin the second 12 months, and vice versa. It's a way of doing a controlled study where all of the participants are guaranteed to get the drug sometime during the study. And this is just our demographics. We were working in the pediatric age group. Because our hypothesis was we're increasing an enzyme that works well, doesn't work well enough, we had to require that there was a minimal amount of what we refer to as residual activity. So go back to my analogy. If you go from 10 to 20%, double activity, and go from 10 to 20%, that's likely significant. But if you're at 1% to begin with and go from 1 to 2%, you won't do much. So we were selective towards milder patients who have more residual enzymatic activity. So we had no serious adverse events during the study. I put an asterisk there because one participant continued on off-label Simvastatin after the study, and she developed cataracts. She was a very mild patient, and it's very unusual to see a child with SLOS develop cataracts outside of the neonatal period or see it in a very mild child. So it's very concerning that this is a side effect of being on Simvastatin. Otherwise, we really didn't have problems in the study, but that puts a big caveat on whether I would decide to put a child on Simvastatin or not. So sterile biochemistry, when we looked in the serum, we did what we wanted to do. I'm not going to walk through these graphs, but basically, Simvastatin inhibited cholesterol synthesis. Cholesterol levels dropped some, but 70-hydrocholesterol levels dropped more. And thus, when we looked at the ratio of the amount of 70-hydrocholesterol to total sterols, that was overall better. So an indication that we improved the biochemistry. We didn't normalize it, but we improved it. We can also look in cerebrospinal fluid. As Dr. Bianconi was saying, we collect cerebrospinal fluid because that can give us an indication of what's going on in the central nervous system. That's where we want to be having a treatment effect. As scary as an LP is, it gives us an insight we can't get from the blood. Because remember, there's that blood-brain barrier that prevents the cholesterol from going in. It also means that molecules, or what we call biomarkers that we want to follow in the central nervous system, aren't necessarily reflected in the blood. And the biochemistry, there was a trend towards an improvement in the central nervous system, but it wasn't necessarily what we call statistically significant. So the drug worked in the periphery like we expected. In the central nervous system, things moved in the direction that we would like them to move. But having a change in sterols, that's a biomarker. What we really want to know is, did we impact any of the behavioral aspects of this disease? And what you can see here is that when we compared the baseline versus the washout phase, so baseline, you're not on drug or placebo. Washout phase, that's you've been off drug or placebo for 2 months. Basically no difference, arguing that, we can, across time, this particular parameter looks to be stable. But when we compare placebo to Simvastatin, we did see a significant decrease in the ABC irritability subdomain. That's one of the subdomains in that ABC checklist. This just happens to be the one we focused on for this study. So this argues that a decrease in that score means that the parents were scoring the participants as being better or less irritability during the time period they were on the Simvastatin compared to when they were on the placebo. And the parents didn't know which they were on. The mixture looked the same, and for all tasted the same, etc. So this was the first controlled study to demonstrate an improved behavior in SLOS in response to a therapeutic intervention. Important point, I told you it was statistically significant. That doesn't mean it's clinically significant. The score was different, but it wasn't a big enough difference to really make a difference in day-to-day life. So it's not clinically significant in my mind. There's also so I want a bigger difference, why don't we push the dose? The problem with Simvastatin is the two-edged sword. You can use the side effect to get a benefit, but eventually it shuts down cholesterol synthesis and you end up in a worse place. In fact, if you do it on cells in culture, you can actually, cells look improved and then they crash and die. So it's a biphasic curve. So you can't push the dose higher. But it is a proof of concept that if you can find drugs or chemicals that increase expression of the enzyme, that could be of benefit to children with SLOS. And those in general, or what we refer to as proteostasis modulators, drugs that either increase expression or drugs that stabilize the enzyme that's there, that prevent the body's quality control system from saying, you're not working well, let's get rid of you. Well, I'd rather have somebody that's not working well than somebody that's not have anybody at all. Of course, my HR department wouldn't agree with me there. Anyway, so to really conclude, in working for a therapy for SLOS, you need to think about three things. Basic science, that's the only way we're going to find out how to approach this. And that includes model systems, high-throughput drug screens, biomarker identification and characterization. Clinical research, that includes both the natural history trials that tell us what can we measure that will be important in a therapeutic trial, and the therapeutic trials themselves. And finally, none of this works unless we have families and patient support. Okay, so just acknowledgments, all the members of my laboratory, past and present, a lot of people from the NIH Clinical Center, and a large number of collaborators that we've worked with over time. Thank you. And the families. Yeah. And Juki. Yes.
Does anybody for Dr. Porter? I'm not sure, but I was wondering, the cerebral palsy and seizures that seem to be a part of SLO?
We have a low percentage of individuals who have had seizures with SLOS. It's not typically a major issue in the majority of our kids that we've seen.
Okay.
Yeah.
We have had seizures.
That doesn't. We
Right.
have had some.
Right.
So that, I think I wouldn't classify it as a seizure disorder where seizures are prominent, but as in any of these disorders where you have malformations of the central nervous system and things aren't quite connected the way they are, it's not surprising to see a low frequency of seizures.
Can I answer the CP question?
CP.
I'm a pediatrician and a clinical geneticist. I'm also boarded in neurodevelopmental disabilities, which is a specialty in pediatrics where we care for children with different kinds of neurodevelopmental disorders, and cerebral palsy falls into that range. So the definition of CP, it's not a diagnosis that gives you the reason why a child has problems. So the definition of CP is to have abnormal muscle tone. So a lot of kids with Smith-Lemli-Opitz have low muscle tone, or hypotonia is a term we often use. So that's one part of a definition. The second part is to have abnormal reflexes on the physical exam when the doctor's tapping with a hammer. And you can sometimes see that in kids with all different kinds of brain abnormalities or problems with function. And then a third definition is developmental delay. So if you put all of these things together, you're going to see a lot of those findings in a patient with Smith-Lemli-Opitz. Does that mean the child has cerebral palsy? In the old days, and I'm old enough that I was practicing in those old days, a lot of people thought of cerebral palsy in patients who had some kind of injury to the brain, like they were born with a difficult delivery and didn't get enough oxygen to the brain, or had meningitis or a car accident or some kind of damage to the brain that caused certain findings that they called cerebral palsy. These days, it's a much more general definition, but it doesn't explain what is going on, what the problem is with the child's development or muscle tone or reflexes. So if you have a diagnosis of Smith-Lemli-Opitz, in my mind, that's the true diagnosis. Does that make sense?
Well, there was one of the articles I was reading online listed cerebral palsy, autism, several things that were in that underneath Smith-Lemli-Opitz. And her muscle tone at birth was very flaccid, and as she's aged, it's gotten, the tones kicked in more and more, and very, very similarities to cerebral palsy.
So, those are various labels, but they're not the diagnosis. The diagnosis
Right.
is SLOS, and you can have symptomatic overlap with autistic spectrum disorder. You can have symptomatic overlap with cerebral palsy. Those are labels to describe a group of kids that might have multiple underlying diagnoses. SLOS is the specific diagnosis and is the cause in your daughter's specific
Right,
case.
I understand that, but it's in that article, it did stay under SLO, those characteristics in cerebral palsy and epilepsy or seizures were one, and she's just casebook as far as cerebral palsy is concerned.
Yeah, no, that's not surprising that there's overlap. In fact, the diagnosis of, if you walk in to get services and you say your child has Smith-Lemli-Opitz syndrome, you're going to get a blank look.
Right.
If you walk in and say my child has autism spectrum disorder, you can get services because they understand it.
Right.
And some of the approaches you use will also work with SLOS. So sometimes labels can be advantageous, okay? But the diagnosis is here, and then I would think of it as the symptoms. So you could think of a malformation, an extra digit,
Right.
is a finding due to the SLOS, the same way as the constellation of things that make up autism spectrum disorder can be found in an SLOS child.
Well, what brought that to my attention, not only that article, but I pulled her medical records and asked for all of them and read through, and there were several things on there that was misdiagnosis that they had them take out. One of them, they had cerebral palsy. We tried to get a wheelchair through Medicare. Actually, it was before that, and they had her diagnosis down as cerebral palsy, so the doctor had actually put down cerebral palsy. I think personally what happened was medical coding a long time ago. They didn't have specific coding for specific diseases, so they may have put her on, put that down for billing purposes or
Yeah,
in a similar
no.
tone.
I have the luxury of being at the NIH, and we don't bill, but I do know that the newer system is much more detailed. And so things would get lumped together that didn't necessarily belong together from an etiological standpoint, but that's the way the billing system worked. Sometimes it's a disadvantage, and sometimes it can be an advantage if the drug company is paying for a very expensive drug for a rare disease, but it's not approved for that disease, but it got lumped together.
Something that happened with that too that's interesting, her tone has been kicking in more and more, so I did some serial casting with an orthopedic doctor in my area, and his comment was she has cerebral palsy. Any child who has that type of tone is cerebral palsy, is what he said. So I find that interesting, different opinions on how they approach different
And I'm
diagnoses.
guessing that he doesn't really know what SLOS is. And that's not a negative.
No,
It's
no.
just, you're going to find very few doctors that are not sitting in this room right now that really know what it is.
He's an older
So,
surgeon that's,
yeah.
he just had said
and
that.
labels are a way of
Kinda
putting a
stuck.
label. So if it gets you something that you need, or gets your child something
Right.
that you need, get your daughter, then I'm not going to object to it and be.
But as a
Be
parent,
hard
we
nosed.
pick up on those things and we believe what doctors tell us. And, you may not know that a younger person that has a young child may think, oh, my child maybe has.
That's an advantage of having a group like this. And on their website, they have all of our contact information listed. And, I think I can speak for all of us. Just give us a call or email.
I just wanted to make one more comment about increasing tone as patients get older, because I have seen that many times. And in fact, I've worked closely with one of our neurologists at Children's Hospital Colorado, and we've done sort of fancy neurologic tests, EMGs and so on, and can demonstrate that the tone, in fact, can change over time as patients get older. So it's very common for babies to be very floppy and hypotonic, and to see the tone, particularly in the lower extremities, become increased over time. And in some of my patients, they've even needed special medications and interventions like Botox to help with that. And so it's true that the tone can absolutely change, but that's not cerebral palsy.
Right, right.
It's there are other reasons for that.
Okay.
Thank you.
Evan is going to be 32, and 3 years ago he got really ill, and we took him to the Cleveland Clinic, and they diagnosed that he had pancreatitis. I believe we called Dr. Porter, and you didn't really know that there was some kind of correlation, but since Kevin just did not respond to anything they did. We were there 8 weeks, progressed into pneumonia and then heart failure, and they put him in hospice. We brought him home, and he did get better. But since he was released, I've had 3 parents call and tell me, in the older children, their child have also had pancreatitis.
Yeah.
So is there a correlation that maybe as they get older or something we could start looking into? My mom also passed away from pancreatic cancer, and one of the other people in the group, their sister also had it.
Yeah, I think this is one of the things, general things in genetic disorders. They're typically defined in the pediatric population, and we're all pediatricians.
Right.
That's the bias in genetics. As you get, by keeping the kids healthier, we probably have more individuals that are older, or by making it known how to make the diagnosis, you end up diagnosing older individuals who wouldn't have been diagnosed in the past. I'm just saying, but the information on adults is still limited.
Right.
And I'm looking at Simona because she's dealt with the numbers, but we've had a few cases of pancreatitis. And so there probably is something going on.
They've all been in their
It's-
late 20s, early 30s
there's
when they had
probably
it.
something going on. This is how we find out in the value of a natural history. Why that's happening, we don't know. What kind of frequency that is, we don't know. But the fact that that there might be this association will help us help future kids, and when we get contacted by a physician saying, well, think about this also.
Well, I think that what bothered me was they said they have no idea why he got it, because he's totally tube-fed. Pancreatitis is only, usually caused by environmental factors. But then they said, well, then we can pretty much guarantee he's going to get it again. And I'm like, ugh. And then
So-
someone told me their kid had it 3 or 4 times.
Yeah, so, we know because we looked across a large portion of our kids, the enzymes that you would follow pancreatitis with are not elevated in children that are not having a problem. We did that because the mouse pancreas looks
Right.
different. But what happens when they get older, how SLOS interacts with some other factor that might predispose to pancreatitis, we don't know. I would,
Is there a
It-
way we could, like, when something like that happens, is there someone we could call so they can start compiling data? I could tell you a lot of what,
Yeah.
Kevin had no albumin in his system.
Yeah.
Like, his numbers should have been around 7, I believe. He was like at 2.
we want to hear about those cases because that's the only way. One isolated case doesn't make an association because it could
Right.
just be something intersecting with SLOS. But when we hear 2 or 3, we're going, okay, this is odd, and start putting that association together. So that's something that's very valuable that the patient community can do. When unusual things happen, let us know, let the community know, because it's only when you're not going to go try to figure out one case of pancreatitis because you don't know
Right.
whether it's associated or not. But when the frequency seems to be higher than you would expect, then that's an indication that something specific may be going on and it's worth trying to sort out.
Maybe that's a great way for my question and kind of the importance of our organization working with you folks. Maybe you could touch a little bit on the collaborative efforts. I know we're going to talk about specific research studies later, but a great way for you to get these answers is for people to be involved with research. And can you say a little bit about that?
So the only way we will get answers is for individuals to engage in research. We have a very formal trial at the NIH where they put up the number. We've been going for 20 years now. You can collect it formally that way, and we're happy to see individuals with SLOS. The other way, in a way that a family group can get involved, is to support a registry. It's less intensive than being able to travel and spend a week with us, but it allows for a collection of that information. They need to be done in a structured manner, but almost assuredly, if a drug company gets involved and is interested in a disease, one of the first things they'll be asking is there a registry? It's much better for those registries to be based in the family group rather than a given pharmaceutical company. Yeah, so, because the pharmaceutical companies own the data then. What you want to do is own the data, and by building a registry, it's a way to collect this information on, okay, you had pancreatitis. Well, all of a sudden we know 3 or 4, or somebody that we've never seen had pancreatitis too. And you can put that information together and it becomes apparent that this is something we need to be thinking about and something we need to be thinking about addressing. Because, I talked about therapies for other disease I study, SLOS here. Just because we don't have a therapy doesn't mean we can't help. And there's many things that, the therapy is not directed to SLOS itself, but it can address the symptoms that you're having and the problems the child is having. So it's important to keep in mind what these other things are so that other preventive aspects of medicine or treatments can be applied when they're applicable.
This morning I was sitting and having breakfast with Dr. Steiner, and I was talking to him about a patient of mine in his 20s who was just diagnosed with testicular cancer. And then I hear today about a patient who has breast cancer. And it just made me start to think, and then I'm sitting here I was sitting next to J.D. Roulet, who told me that there was some papers that had reported an association between the oxysterols that you've heard about today, and I'll talk a little bit more about it tomorrow, and a predisposition to cancer. I've been married now for 42 years this week to a medical oncologist who does a lot of research, and one of the first things I'm going to ask him when I go home is, does he have any connections with people who are looking at oxysterols, and how we could look at that a little bit better. So I think coming to these kinds of meetings and sharing your questions and your information opens up whole new areas of thought and potential research that can maybe someday find an answer, and that's really exciting.
Hi, my question is, I live in Canada, so I've never been able to be part of any
You
of
have
these.
health care.
I have health care. And you should see my daughter's file. It's like, yay big. But anyways, I remember one time she had something, and I asked my geneticist, I said, you know, why wasn't I told about this? I can't remember what it was. And he said, well, Lynn, don't forget. He said, after 18 years old, we don't have that many survivors after 18 years old, but, you know, especially in the severe spectrum. But now that she's 32, I'm looking at something that's completely different. And I found a 47-year-old, which is the first time in a long time that I see someone that's older than Julie. So I know some of the stuff might come up that we don't know about, but is there any possibility to even like registry for me, even though I'm in Canada?
So I think we should put this on the topic for the meeting tonight about an idea of a registry.
I
So-
think this would be an excellent topic for our meeting
Yeah.
tonight.
Yeah, so it's, you know, another thing to add, realize that the diagnostic test for SLOS really came into play in the mid-90s. Yeah. Okay? Prior to that, if you classically looked at SLOS, you got the diagnosis. If you weren't classical, it was unsure. So the biochemical testing came in, and then soon after that, the genetic testing came in. So the ability to test, I have a feeling for a while, every child with 2,3-toe syndactyly, and I would say this at pediatric meetings, you have a child with 2,3-toe syndactyly and some other problem, you should test them. Biochemical testing is pretty inexpensive. That expanded the diagnostic, the spectrum in our understanding. That's how we pull up. I mean, the woman who was pregnant was actually a special ed teacher. I didn't believe she had SLOS until after the pregnancy was done. I thought it was something, she was a carrier, and it was something funky with women's, I shouldn't say funky, women's cholesterol metabolism during pregnancy is different. And you're supposed to elevate your cholesterol during pregnancy. And I thought she was just making some 7-dehydro because she's a carrier, but genetically she's not.
When I was pregnant, I had problems with bowel acid.
With bowel acid?
Yeah.
Okay.
Put me on medication until I had my baby.
Yeah.
And for both 3 months, my last trimester, so.
Yeah, there's very little data on it, but there was one nice study, I'm going to blank at who did it in the 90s, followed a woman through her pregnancy, and Mira. No, it wasn't Mira. I didn't think. Anyway, it doesn't matter, but the expected rise in cholesterol didn't increase.
Is the lady with who you found, is she the mildest case, and are you finding other ones like that?
So I haven't met her personally. That was a case we were consulted on. Okay. So it's probably the highest functioning individual that I would say biochemically and genetically qualified as having SLOS, but there's obviously something going on with her 20,000 other genes that
Well, it might be.
That modulated this. Yeah.
It might be just the perfect time for us to give, not ending this, but I really want to give our physicians, especially this team of physicians here and Dr. Tierney, a warm applause for all they do for us, not not only here, you just touched on where my appreciation, it's all the other times when we are in crisis, or we have a behavioral problem in the middle of the night, or whenever, and these physicians have extended themselves well beyond normal working hours for our families. But it also brings up a great question, and I'm bringing it up today instead of tomorrow because Dr. Steiner's here. How accessible are you, and will you continue to be, for our family physicians to give a consult for one of our kiddos that's going in for surgery or whatever? Can you all speak to that? Especially in a crisis.
Always available,
I mean,
24/7.
I may have dittos, but pretty much available. I mean, you know, by email or by calls, we frequently get calls from physicians. So,
Please call and email.
yes.
And if I don't answer, do it again.
Yeah, I'll emphasize that. If you don't hear an answer, please repeat, especially on email, because, you know, things end up 10 pages down on that email, and it can be a mess, and especially if we're out of town trying to catch up. I was out last week, and I finally had made a decision yesterday that if I hadn't gotten to an email, I don't know about it, and they're going to email me again if it's important. Because
All,
Email is the best because, and I answer questions and calls and emails all the time, every week, from families and also from referring physicians. So, you know, I'm in clinic every day, and when I'm in clinic, my phone is off because I'm caring for patients. And I never make it to my office where my phone messages sit, sometimes till the very end of the day or sometimes not for a couple of days. So email is definitely the best for me.
and if you know we have a study coordinator or a nurse, copy them. They're really good at did you answer? So.
and just because I knew the answer sort of for that question, but it's a great reason to keep a copy. They've all put their information, all of their information, within the Smith-Lemli-Opitz new digital guide that is downloadable online. You got a copy with your materials, but these are part of our very important medical advisory board, and all of their information and where to contact them is in there. So thank you, more than you ever know.
If I can, if there's a behavioral issue and you're going to be seeing your physician, please contact me ahead of time so I can talk through the situation and give you questions, because, of course, behavior is there's so many factors to it. And that way also, if you could do it weeks ahead, so because I'm not answering emails on some vacations now. So.
Good for you.
Hello. So what brings Greg and I here, we have a son who's 18, and we've sort of been out of the loop a little bit because we've been having, you know, some great years. But ironically, now that he's 18, we're starting to have some issues physically and some behavioral things. So what we were trying to do is find a bridge. You know, now we're leaving the pediatric scene. Some of our doctors that have followed us won't be able to see us, even though some say till 21. So we were curious as to what some of the other families might be doing, transitioning, or is there a transition physician kind of thing? And in
One quick comment is, I think we alluded to this earlier, as geneticists, virtually all of us are comfortable seeing adults. And your geneticist is likely to be the most knowledgeable about SLOS in general. So a clinical geneticist or a clinical biochemical geneticist or a metabolic geneticist generally is a good person to follow an individual with SLOS throughout their lifetime. And they can be the point person to work with the other specialists.
Okay, so that's ironic too, because for the first time this summer, we have an appointment with a metabolic specialist at CHOP. But my understanding is that they're not really very well informed with SLOS, so I feel like getting a plane ticket to come see some people.
And we hear, I think I speak for all of us, we hear from physicians all the time who have a new patient with SLOS, don't necessarily know a lot about it, but want to learn more or have a specific question. All of us are answering questions from other physicians all the time, and we're
I know.
happy to do that.
Thank you. I know our neurologist had reached out to you, Dr. Elias, because Quinn was having these unusual episodes, and after seeing some of the information today, I'm sort of wondering if he was in like some kind of an adrenal crisis, and they just didn't pick it up as that. But she did reach out, and that's what got us connected to the metabolic via her conversation with you. Super.
So the whole question of transition is a really big one. My clinic, we have more than 4,800 children with medical complexity and special needs with many, many different underlying diagnoses, and Children's Hospital gets really wigged out when a 35-year-old patient shows up in our emergency room. But sometimes it's the geneticist who really knows about that disease. So what we try to do is find a good, solid primary care provider, local in your community, who can help deal with the acute emergency medical problems. So it's always good to have a local primary care physician. And then that person can reach out to the specialists and to try to find answers for something that looks unusual. So that, that is what I tell all of my patients as they become 18 and older. We try to find a good pediatrician for them in the community, and then we can work together as a team, all of us.
So that's what we were thinking about. Maybe we had a family practice that was following us, and that was great, and then he decided to leave the medical profession for insurance things, and then we went to the pediatric side, but now we're still at that juncture where we want to go. So it's just a matter of due diligence and trying to find the right fit. We haven't even used a geneticist besides Dr. Porter when Quinn was an infant to this point either. So I guess maybe we'll have to go for some recommendations who you might recommend in our area in Philadelphia, or, still stay connected with your groups. Thank you.
47 years of questions built up. Sorry, but like I said, it's 47 years of questions built up that nobody's been able to answer. And I've not been able to talk to anybody that had any similarities. So since Carrie was born in 1972, I didn't know it until I was researching the cancer. I got a hold of Dr. Kelly. I remembered that name because he's the one that found, I guess, the cholesterol levels. Anyway, he told me, he told me that he would have her in his registry if she had been diagnosed. He pulled it up. She's not in there. So I think what happened, Dr. Opitz actually diagnosed her she was diagnosed by a pediatrician at birth, and then we reconfirmed it by going to Madison and talking to Dr. Opitz, and he said, yes, she's casebook on everything as far as Opitz is. So, but she's never actually gotten a test to prove that. And I also want to know if there's any overlapping of diagnoses, because in addition to that, she has one central incisor, and that's not similar, and that's not anything for Smith. Is it? Well, see, there again. And so the university tried to give her another diagnosis, in fact, to diagnose it over SLO because of the division in the brain and why she has a central incisor. So there again, see, all these years, we've found all kinds of questions and confusion on that.
So these midline defects, including a single central incisor, are features of SLOS.
Really?
They are features of other conditions as well, but definitely a feature of SLOS. But I think these days, if there's a patient who was diagnosed before there was biochemical or genetic testing available, our general recommendation would be to go ahead and try to get that testing done, either biochemical or genetic or both.
Even if Dr. Opitz actually said it, and if you go by everything
Even if Dr.
she has.
Opitz said it. And he would probably agree with us.
Yeah, I tried to get a hold of him at Salt Lake City, actually, when this all came about, and I was searching for somebody about SLO. They said he was writing a book, and they would not give me his number, my number, or anything, which I found was interesting. But anyway. Well, he wouldn't.
He's generally quite available for patients, although he is fairly advanced in age and has had some health problems. He's
Is
probably
retired.
over 80
Yeah.
years old,
Oh, I'm sure.
well over 80.
Yeah.
It's been a few years.
Well, and I can't imagine, having visited with him, I couldn't imagine if he found out that I was trying to research that he wouldn't have responded back.
Yeah, he's
because-
very good at responding.
Yeah.
Oh, sorry. I had just asked if there were any protocols in reference to testing genetics for siblings, because Quinn has a 21-year-old sister, and
Right.
she's got some anomalies, and she's getting to the age where, am I a carrier, am I not, which we're
Generally,
guessing
it's
she is.
very reasonable to test siblings. It's great to get the insurance companies to pay for it as clinical testing. Sometimes that takes some work. Sometimes the first answer from the insurance company is no, but don't take no for the final answer. Ask your genetic counselor or the geneticist to be persistent about it. And we've been, by and large, successful in getting the siblings tested and the testing paid for.
Okay. Yeah, what age?
Whenever you're thinking about it.
We have a genetics counselor that's going to be talking about this exact same thing also. Go ahead.
When you ask the question, what age, it's really a reproductive question. So it's not the parent's choice. It's your child's choice. So typically, most geneticists would say it should be their decision to get tested if they want to know whether they're a carrier or not. Yeah. Because it doesn't have that health.
You were saying the sibling had some features as well.
Oh.
If the kids are young enough and have features.
If they have if I have any question that the child might have a diagnosis, I'm testing. But if it's a pure reproductive decision, then 18 or when they have a significant other that they could be at risk of having a pregnancy, then they should make the choice to be tested if they want to or not. Oh, no. If Quinn's mutations are known, then you provide that information to the genetic testing company. What I suggest in those cases, because it's important for somebody to really sit down and talk through, because the risk is actually low, although if it's in your family, you're worried about it. I suggest that they would talk to a genetic counselor and then make a decision whether they want to know whether they're a carrier or not, because then you start down a whole path, because if they're a carrier, then you have to test the partner, and that's not as easy as testing the carrier where you know what you're looking for. And nothing is 100%, so it's important, or 0%. So it's important for them to talk to a genetic counselor so they know exactly what it means when they get that result.